Mobility and immobility. Today we'll be looking at assistive devices for immobility. And we're going to start with the tilt table. Okay, so there's a picture of the tilt table, and you can see blood pressure curve on the patient. So the tilt table is used for weight bearing on long bones to prevent decalcification of bones and resulting bone weakness, including renal calculi formation. It also helps to stimulate circulation to lower extremities. You would want to use elastic stockings to prevent postural hypotension. Okay, compression stockings and garments, they help to reduce the pooling of blood in the legs. Okay, so that's what those elastic stockings are going to do, and reduce the symptoms of orthostatic hypotension. Again, you want to tilt and move the patient gradually, and the board can be tilted in increments of between 5 to 10 inches, okay, or 10 degrees, sorry. So you can increase 5 degrees, monitor your patient, increase another 5 degrees and all of that. Blood pressure should be checked during the procedure. And again, if blood pressure goes down and there's dizziness or pallor or diaphoresis or tachycardia or nausea, if any of these occur, you want to immediately stop the procedure. Let's look at crutches. What are the guidelines for crutch usage? So from the pictures, you can see that's a radial nerve that could be damaged, especially if the patient leans on the crutch or if she weight bears on this part of the crutch. Okay, so you want to at least measure 2 finger breadths below the axilla. So you want that 2 finger breadth between the axilla and the pad. So that should be about 1 to 2 inches or 2 to 5.5 cm. Again, the client should support weight on handpiece. So you want the client to support his or her weight on a handpiece. Okay. Not on the axilla, because it could result to damage of the brachialis plexus, which will produce what we call crutch palsy. Okay, so this is where they should be bearing weight. And the crutches should be kept 8 to 10 inches out to side. Okay, 8 to 10 inches. Again, elbows should be flexed at between 20 to 30 degrees elbow flexion for correct placement of hand grip. And again, stop and rest if the patient gets short of breath or becomes diaphoretic. A walker is a metal frame with hand grips and 4 legs. So this 1, 2, 3, and the other one on the other side. Used for clients who need greater stability than that provided by other ambulatory aids. We also need to look at the guidelines for using walkers. The elbows should be flexed again at 20 to 30 angle degrees when standing with hips on the grip. So like we saw with the crutches. Again, you want to lift and move the walker forward 8 to 10 inches. Okay, so you can see that distance. You want to lift and move the walker 8 to 10 inches forward. Again, with partial or non-weight bearing, put weight on wrist and arms and step forward with the affected leg, supporting yourself on arms, and then follow with a good leg. Okay, so always remember with the walker, bad leg first. The nurse would also want to stand behind the client and hold on to a gait belt, which is one at the waist, in case the patient becomes exhausted or wants to fall. You want to hold on to the gait belt to support the patient. Again, sit down. The patient should be taught to sit down by grasping the armrest on the affected side. And then he can now shift his weight to the good leg and the good hand, and then lower himself onto the chair. And always advise the client to wear sturdy shoes for safety. So let's look at the cane. Remember, we could have a straight cane, which gives the least stability. There's also the quad cane, which is quad, means four, which has four legs and provides more stability. So this would be a straight cane. So what are the guidelines for use? The tip of our cane should have concentric rubber rings. This will act as shock absorbers and provide optimal stability. So again, the tip should have rubber rings. Again, you also want to flex the elbow 30 degrees and hold the handle. The tip of the cane should be 15 cm lateral to the base of the fifth toe. Okay, so you want to have that space, at least 15 cm to the side of the base of the fifth toe. Same almost, remember with the crutches, it should be kept between 8 and 10 inches out to the side. But for a cane, hold cane in hand, opposite affected extremity. So you can see the darker foot is the affected extremity. So you want to hold the cane in the opposite hand. Advance cane and affected leg. So you can see you want to move both the cane and the affected leg, and then lean on the cane when moving good leg. So now you can see you lean on the cane and advance the good leg. To go up the stairs, let's look at going up the stairs. Please remember, these are popular NCLEX questions, especially regarding to the cane. So to go upstairs, step up on good extremity, so that's the good leg. Then place cane and affected extremity on step. So again, up with the good if you are going upstairs. And the reverse is the case when you are going downstairs. So you want to place the bad leg and the cane down first and follow with the good one. So remember, up with the good, down with the bad when you are using cane. Up with the good, down with the bad. The Hoyer lift is used for clients who cannot help themselves or are too heavy for safe lifting by others. It's a mechanically operated metal frame with a sling, usually made of canvas strap. So that's a canvas strap that's attached to the frame. So you want to lock the bed and raise the bed to your level to promote use of good body mechanics. Again, position the lift base under bed and center the lift arm over the canvas sling. Always remember to lock the lift wheels. So instruct clients to cross arms over chest. One person will help you guide the lift, while the second person lifts the leg of the patient off the bed and steadies the sling. Position the wheelchair between the lift base legs, lock the legs, and lift the wheels. One person slowly releases valve to lower arm, while second patient will now guide the client into the wheelchair. So this is another assistive device. The slim board is used to assist patient move from the bed to a chair or a wheelchair. So you want to place the wheelchair close to the bed and lock the wheels of the wheelchair. You also want to lock the bed. Remove the armrest from the wheelchair. Powder the sliding board because he's going to be sliding down the board. Place one end of the sliding board under the client's buttocks on the bed, then the other end on the surface of the wheelchair. Instruct the client to push up with hands to shift buttocks and then slide across board to the wheelchair. You also want to assist the client to slide gently off the bed. Adaptive devices. These are equipments that are used to assist with completing activities of daily living. Your bathing, your dressing, your grooming, toileting, feeding. These are all self-care activities. One adaptive device is your button hook. This button hook is threaded through buttonholes to assist the client with buttoning of his shirts. There's also the extended shoehorn. Remember, the shoehorn is a curved instrument that is used for easing your heel into a shoe. So you can also use this if it's extended, if it has that extension, you can use that to turn light switches on and off from your wheelchair. We can also put gel pads underneath plates to prevent them shifting or moving around. You can also put foam build-up on utensils, pen, pencils. So this is an example of how you can use Velcro straps to stabilize your utensils in the patient's hands. There are also long-handled reachers. This would help to obtain objects from a high or very low location. So these are just adaptive devices. Therapeutic exercises. One form of therapeutic exercise will be passive range of motion, which is performed by the nurse with no assistance from the client. You're passively, the patient is just passive, he's not active, he's passive, and you are carrying out the range of motion exercise. So the rationale for this is you're trying to retain joint range of motion and also to help maintain circulation. There's also active assistive range of motion. This is now performed by client with assistance from the nurse. So you can see here, the patient is active and there's the assistance from the nurse. This will help to increase joint motion. There's also active range of motion. This is actually performed by the client with no form of assistance from the nurse. We also want to maintain joint mobility and increase muscle strength. There's also active resistive range of motion. So now the client is performing these exercises against manual or mechanical resistance. And all these exercises, active resistive range of motion exercises, would help to increase muscle strength. And you can use weights like a 5-pound bag as a form of resistance for the patient to move against or to exercise against. And then there's isometric exercises, which are performed by the client. There's alternate contraction and relaxation of muscles without actually moving the joints. So you want to help maintain muscle strength, especially when you have a joint that is immobilized. So what are complications of immobility? First, there could be tooth ulcer. Remember, this forms where the pressure from the body or the body's weight presses the skin against a firm surface, such as a bed or a wheelchair. So this pressure cuts off the blood supply to that area of the skin and injures tissue cells. So what are the sequels from this? So what could result from this complication? There could be osteomyelitis, there could be tissue maceration, there could be infection. Our nursing considerations would include frequently turning your patient, providing good skin care. Again, if the client is mobile, you want to ambulate as appropriate. Use your draw sheet when turning to avoid the shearing forces that can injure the patient. Provide the client with good balanced diet, adequate proteins, vitamins, and minerals. Again, you want to use air mattresses or flotation pads or elbow and heel pads, even sheepskins, to reduce the pressure on the skin. Again, assist with use of striker frame or circuletric beds. So these beds are able to move around, take different inclinations and all of that, just to aid with reducing or relieving pressure on areas of the body. There could also be sensory input changes where you have the client is confused, he's disoriented. So you want to orient your client frequently, put a clock and a calendar in the room so he's able to reorient himself to the day and the time. We could also have osteoporosis. which is a condition in which the bones become weak and brittle. As a result, we could see pathological fractures. We could see buildup of renal calculi. So you want to encourage weight bearing on long bones. We saw the tilt table. This could be useful here. Provide balanced diet. Monitor estrogen therapy if ordered, okay? So you also want to look at all of this. Again, negative nitrogen balance. What is negative nitrogen balance? Again, it represents a depletion of protein stores that are essential for building muscle tissue and also for wound healing. So if your client is immobile, it could develop this complication, negative nitrogen balance. So we could see anorexia, we could see debilitation, we could also see weight loss. Again, you want to give high protein diet and small frequent feedings. There could be hypercalcemia, buildup of calcium, excessive buildup of calcium, which could cause impaired bone growth. So again, you want to monitor the client's diet, encourage fluids, and reduce calcium in his diet. Again, another complication would be increased cardiac workload, which could lead to tachycardias. So you need to teach the client how to use the trapeze when he's standing up or moving in bed, so as to reduce or decrease the Valsalva maneuver. Remember, when he inadvertently does the Valsalva maneuver, when he tries to lift himself from bed, like holding his breath or bearing down, that could increase the heart rate. So you want to teach him to use the trapeze and also teach him how to move without holding his breath. Again, there could be contractures, which is a fixed tightening of muscles, tendons, ligaments, or skins. It could result to deformities. So again, you want to frequently change positions. Use pillows, the trochanter roll, footboards to promote proper body alignment. And again, exercise as appropriate. Other complications would include thrombus formation, which could lead to a pulmonary emboli. A pulmonary emboli, again, is a blood clot that occurs in the lungs, and it can damage part of the lung due to restricted blood flow and decreased oxygen levels in the blood. Part of your nursing considerations would include leg exercises, flexions, extension of toes for 5 minutes every hour, ambulate as appropriate, change of positions, avoid using knee guards on bed or pillows to support knee flexion. Use your elastic hose, you need that compression. And again, always assess for edema, warmth, and pain. We could also have another complication, orthostatic hypotension or postural hypotension, where you have a drop in blood pressure upon standing. You'll notice weakness, faintness, dizziness. So teach your client to rise slowly from bed and also to gradually increase his activity. There could be stasis of respiratory secretions from immobility, which could lead to hypostatic pneumonia. So this would be a pneumonia that usually results from the collection of fluid in the dorsal region of the lungs and usually occurs in bedridden or elderly clients who are confined to a supine position for extended periods. So teach the client the importance of turning, coughing, deep breathing, and again, administer postural drainage as appropriate. The client could suffer constipation. We'll see fecal impaction, so you want to ambulate as appropriate. Remember, fecal impaction is a severe bowel condition in which a high dry mass of stool becomes stuck in the colon or rectum. So the patient or the client will be unable to pass this mass. So you also want to ambulate, increase fluid intake, increase fiber in the diet. When the patient cannot go out of bed, encourage privacy when he's using the bedpan or the commode. And you want to administer Coles or stool softeners. There could be urinary stasis, where you will see urinary retention, renal calculi could start developing. So have the client void in normal position if possible. You also want to increase his fluid intake, low calcium diet because of the buildup of the renal calculi, increase acid ash residue to acidify the urine and prevent formation of more calcium stones. Boredom is another complication from immobility, and this could be seen in your patient when he's restless. So please allow visitors use of radio, television. Again, you want to schedule occupational therapy. Another complication will be depression. The client will suffer insomnia, even restlessness. So you want to encourage self-care. Start with simple gross activity before you advance to finer motor movements. Increase periods of activity as fast as client can tolerate. And again, support the client with positive feedback for every effort or accomplishment. Let's look at some specific therapeutic positions. So this would be supine position. It avoids hip flexion, which can compress arterial flow. So this is our supine position. There's also the dorsal recumbent position. So you're also supine, but with the knees flexed. It's actually a bit more comfortable. There's a prone position, promotes extension of the hip joints, but it's not well tolerated by persons with respiratory or cardiovascular difficulties. There's a side lying or side lateral position. This position will allow drainage of oral secretion. So remember, in your NCLEX, always ask yourself, what do I want to achieve by this position? Don't just go selecting any position. What am I trying to achieve by putting this client in this position? Okay, let's continue. There's also the knee chest position. So this will be our knee chest position for maximal visualization of the rectal area. There's also side with upper leg bent, which is the Sims position. So you can see the upper leg is bent. This will also allow for drainage of oral secretions, and it also decreases abdominal tension. There's a Fowler's position. The head is elevated. This increases venous return. It allows maximal lung expansion. The high Fowler's is between 60 to 90 degrees. The regular Fowler's is between 45 and 60 degrees. The semi-Fowler's is between 30 and 45 degrees. And the low Fowler's is between 15 to 30 degrees elevation. There's a modified Trendelenburg's position. Here, the feet is elevated 20 degrees. The knees are straight, the trunk is flat, and the head is slightly elevated. There's also head elevated and knees elevated. What do we need to achieve? To increase blood return to the heart and also relieve pressure on the lumbosacral area. You could also elevate the extremities to increase venous return and also decrease blood volume to the extremity. And finally, there's a lithotomy position. So this will be our lithotomy position, which helps to increase vaginal opening for examination. Let's look at joint movements. We'll start with flexion. So this would be our flexion, where you have decrease of or decreased angle of joints. Example, bending the elbow. So for here, this would be our knee. So we are bending the knee back. So this is our flexion, and extension would be increasing the angle, like straightening your knees. There could be hyperextension. With hyperextension, there's excessive increase of the angle of joints, like bending the head backwards. So that would be hyperextension. With abduction, so this would be our abduction. With abduction, there's moving body away from midline of body. So this is our body here. When you are moving that body part away, you are abducting the hand. So this is abduction of the hand. And adduction is moving body towards midline. That's like adding to the body. So add to the body, adduction. There's also rotation. So this would be rotation, moving bone around the central axis. There's also dorsiflexion. So this would be our dorsiflexion, flexion of the foot toward the trunk of the body. So you can just say toes towards the nose. That's dorsiflexion. While plantar flexion would be flexion of the foot away from the trunk of the body. That's like pointing the toes. That's plantar flexion, almost like you are trying to plant the toes on the ground. So that's plantar flexion. There's also inversion, which is turning the foot inward at the angle, and eversion, which is turning the foot outward at the angle. We also have pronation. So this would be our pronation over here. Positioning of the forearm so that the palm of the hand turns downwards, while supination would be rotating the forearm so that the palm of the hand turns upwards. Let's look at mobility. In terms of mobility, part of your assessment would include look at the posture, you're looking at body alignment, and we could have some problems with posture. For example, we could have lordosis, which would be an exaggerated concavity in the lumbar region. We could also have kyphosis, which is exaggerated convexity in the thoracic region. And then we could also have scoliosis, which is a lateral curvature of the vertebral column. So this would be scoliosis, this would be kyphosis. In terms of mobility, we look at activity. Mobility is a form of activity that maintains muscle tone and posture. It also serves as an outlet for tension and anxiety. Exercise maintains joint mobility and function. It promotes muscle strength, stimulates circulation, promotes optimum ventilation, it stimulates appetite, promotes elimination, and enhances metabolic rate. So what's your plan and implementation in terms of mobility? For someone who is mobile, you want to avoid injury. Prevent motor vehicle accidents with the use of seat belts and helmets. Again, follow safety procedures to avoid job-related accidents. When you're engaging in contact sports, perform proper body conditioning and use protective devices. For the aged or the elderly, rugs in the home should be secured to avoid falls, light up the stairways, and the area of movement should be clear of debris or trailing wires. Again, during pregnancy, use bathtub grips to avoid falls. Avoid high-heeled shoes. Again, in assisting your client to sit, you want to place hand under the knees and shoulders of the client. Instruct the client to push elbow into bed. At the same time, the nurse should lift the client's shoulders with one arm and swing the client's leg over the edge of the bed with the other arm. So that's how you should assist your client to sit on the side of the bed. Again, if you want to assist your client to stand, face the client with arms firmly grasping each side of his or her rib cage. Push your knee against one knee of the client. Rock the client forward as he or she comes to a standing position. Then pivot client to position him or her to sit in the chair. Always remember that the client is placed on the stronger side. Again, to assist the client out of bed, if the client has a weaker side, move the client toward the stronger side because it's easier for the client to pull the weaker side. Use the larger muscles of the leg to accomplish a move rather than the smaller muscles of the back. Good body mechanics. Draw sheets are a better method of moving a client than sliding the client across a surface. And always have an assistant standing by if there's any possibility of problems in completing a transfer. Also, teach activities of daily living. Observe what the client can do and let him do it. Allow him to do it. Encourage the client to exercise muscles used for activity. Again, start with gross functional movement before going to finer motions. Extend periods of activity as much as and as fast as the client can tolerate. Give positive feedback immediately after every accomplishment.